So iron deficiency is a very important comorbidity that we always screen for heart failure patients. So our final talk in this session will be with Dr. Marta Ramos. So this is a very important and common problem that you deal with in internal medicine. So we're talking about stroke prevention and atrial fibrillation, anticoagulation, and beyond. Dr. Marta has recently joined Rashid Hospital Cardiology Department as a consultant cardiologist and electrophysiologist. She came to us from Spain, Barcelona, from the Bellevitch University Hospital, where she used to work there as a consultant electrophysiologist, and I think we're all eager to hear what she has to say.
Okay, thank you very much for this nice introduction. I hope you can keep some attention after the excellent speech of my the previous presenter, my ex-chief from Barcelona. As you can see, he knows a lot about molecules, and he's very deep into research. This is not my. Yes, this one. The subject of my speech is stroke prevention in atrial fibrillation. To start with, I would like to emphasize the importance of collaboration between departments. The management of AF starts at the patient level and includes many disciplines: internal medicine, cardiology, family doctors, radiology, and we have to work together to give the best treatment at the earliest. This is the 4S AF scheme proposed by the latest European guidelines in 2020 to assess the approachment for AF treatment. And one of the most important things to be characterized in AF is the risk of stroke. And this is going to be the center of my talk. These are the 4 points I'm going to follow during this talk. First of all will be stroke assessment, then bleeding at risk assessment, stroke prevention in different scenarios like electrical cardioversion, ablation, subclinical AF, and ischemic cardiomyopathy, and finally, stroke prevention in high bleeding risk patients. For the stroke assessment, CHATS-VASc is the preferred score for the European guidelines and also for the American guidelines. Everybody knows this score, how to calculate it, so I'm not going into detail. For a CHATS-VASc of 2 or more in men and 3 or more in women, it is mandatory to anticoagulate. And for CHATS-VASc 1 in men and 2 in women, it is also recommended individualizing each case and based also on the patient preference. Never give aspirin to these low-risk patients as in the old days, as it doesn't protect from embolic events. This is very important. But let's not forget that there are other risk factors not so well defined as independent risk factors, and then not reflected in the score. Many of them probably represent a risk of thromboembolism per se, like malignancy, renal dysfunction, or amyloidosis. Just a comment in the case of hypertrophic cardiomyopathy, as there is a recommendation for anticoagulation in patients with hypertrophic cardiomyopathy and AF independently from the CHATS-VASc. And there can also be markers from imaging, from echocardiography, for example, LA dilatation and spontaneous contrast, which mean less mechanical contraction and a higher risk of thrombus formation due to that. Other considerations to take into account is that a high risk of bleeding cannot prevent the initiation of anticoagulation for stroke prevention unless there are contraindications for anticoagulation. Secondly, although there is an increasing evidence that the more AF burden, the higher is the risk of stroke, the indication for anticoagulation should not be based on the AF pattern or burden, but on the CHA2DS2-VASc only. And third, the guidelines emphasize the importance of risk reassessment. Many patients are firstly diagnosed of AF without knowing that they are hypertensive or they are diabetic. So reassessment after 4 to 6 months of first diagnosis is very important. And which anticoagulation to choose? I think this is very, very clear. The guidelines give preference to the new anticoagulants as they have demonstrated less bleeding and superiority or non-inferiority compared to vitamin K antagonists. And we all have seen the advantages during the pandemic, the advantages for planning cardioversions or for any procedure that requires previous anticoagulation as AF ablation. Here you have the dosages and the pivotal trials for each of the NOACs. The risk of bleeding is usually calculated with the Hasbled risk score. Low risk is a result between 0 and 2, and 3 or more means high risk. And as I said, Hasbled of 3 or more should not withhold anticoagulation as the benefit of preventing stroke is higher. Let's talk about anticoagulation in different scenarios. The mechanism to explain the elevated risk of stroke after cardioversion is atrial stunning after the shock and the initiation of effective atrial contraction after sinus rhythm restoration, which can provoke the migration of a previous thrombus. As you know, it is recommended to anticoagulate 3 weeks before cardioversion or in alternative to perform a transesophageal echo to exclude the presence of thrombus in the atrium if you don't have these 3 weeks of time. And if the duration of the episode is less than 48 hours, cardioversion can be done without previous anticoagulation, and either a transesophageal echocardiogram is not required. One of the novelties in the last European guidelines is the possibility to withhold anticoagulation after cardioversion if we are absolutely sure that the AF episode is less than 24 hours duration and the patient has a low CHA2DS2-VASc risk of 0 or 1 in women. Anyway, this is based on observational data, so the level of recommendation is only 2B, and we have to be very careful applying this timing for anticoagulation after electrical cardioversion. When it comes to AF ablation, preparation of the patient is very, very, very simple. The patient has to be prepared as per the cardioversion, independently, in this case, of if the patient is in AF or not. After the procedure, anticoagulation has to be continued during 2 months and then follow recommendations based on the CHA2DS2-VASc of the patient. It is very important to consider that ablation is not done to avoid anticoagulation, but to relieve symptoms and reduce episodes of AF. And the earlier is performed, the better are the results. Regarding coronariopathy and atrial fibrillation, we have to distinguish acute and chronic coronary syndrome. For acute coronary syndrome is in the upper part. For acute coronary syndrome, the recommendation is to give dual antithrombotic therapy, preferably with a new anticoagulant together with clopidogrel for 1 year, and then continue only with a new anticoagulant regardless the type of stent. And for chronic coronariopathy syndromes, instead, the extension of the dual antithrombotic therapy should be 6 months, and then continue new anticoagulants long-term. In both cases, triple therapy with aspirin should be given after PCI up to the first week, and only when there is a high risk of stent thrombosis, this triple therapy can be given up to 1 month. In the case of thrombolysis, dual therapy with new anticoagulants plus clopidogrel is preferred up to 6 months, and then continue NOAC long-term. Other considerations regarding PCI and atrial fibrillation is that NOAC are better preferred than vitamin K antagonists because of their better performance in terms of bleeding and efficacy, and in patients at high risk of bleeding. If we give rivaroxaban, the dose should be 15 milligrams daily, and the dose for rivaroxaban, dabigatran, sorry, has to be 110 milligrams twice a day, as per the redual PCI study. In the last years, attention has raised on the episodes of atrial high rate seen through pacemakers, defibrillators, or any cardiac monitor device. Some studies have shown that ARE, atrial high rate episodes, or subclinical AF, have less risk of stroke than clinical AF. But some studies have shown also that the higher burden of silent AF, the higher the risk of having episodes of symptomatic AF. It is getting more clear that if during the follow-up of these devices we see a tendency to an increase in the burden of atrial episodes, and especially if these episodes are lasting more than 23 hours, it is better to anticoagulate the patient, based on the CHA2DS2-VASc, of course. In the left panel, you can see the transitioning to longer episodes increases the risk of having even longer episodes. And in the right panel, you can see how having episodes of more than 23 hours together with a CHA2DS2-VASc of 2, or having episodes of less than 23 hours but with a CHA2DS2-VASc of 3 or more, increases the risk of stroke significantly. So this is the proposed algorithm for the European guidelines for the management of these asymptomatic atrial episodes detected by cardiac monitors. They consider oral anticoagulation for the episodes of 24 hours or longer, and CHA2DS2-VASc of 2 or more for men, and 3 or more for women. For the rest of cases, the advice is to follow up the patient and reassess regularly, and preferably with remote monitoring, which means that the device will send information to the hospital regularly, so the patient won't have to come to the hospital so often. And the last point of my talk, in case of high risk of serious bleeding under oral anticoagulation, or in case of stroke under oral anticoagulation, we can close the left atrial appendage percutaneously, as the 90%, as you know, the 90% of the thrombus are originated in this part of the atrium. The alternative to the percutaneous closure is surgical ligation of the appendage, but this is only to be considered for the moment during other cardiac surgeries and not as a single surgical procedure. These are the most common implanted percutaneous devices, the Watchman in the left and the Amplatzer in the right. And the more recent, after the learning curve studies that we have, the PREVAIL, the ASAP, and the EVOLUTION, have shown the safety of this procedure with about 4% of complication rate and a high percentage of implant success. Similar efficacy for stroke prevention compared to warfarin has been observed, and less bleeding in the long term. Oh. Besides, evidence is growing. Okay. Besides, evidence is growing regarding the safety of the dual antiplatelet therapy in continuation with single antiplatelet therapy in the post-procedural treatment, so we can avoid the need of anticoagulation post-procedure. And these are images of procedures performed in our center in Rashid Hospital. First we have to do a transeptal puncture, and then the device is deployed in the left appendage under transesophageal echo guidance. So in summary, these are the conclusions. New anticoagulants are generally preferred over vitamin K antagonist. The preparation of patients either for cardioversion than for AF ablation is the same, 3 weeks of NOAC or transesophageal echo pre-intervention. In patients with AF and PCI, NOAC plus clopidogrel is the preferred treatment with a duration between 6 and 12 months, followed by NOAC long-term. In subclinical AF episodes diagnosed by cardiac devices, or oral anticoagulation is recommended for episodes lasting 24 hours or more, and CHATS-VASc 2 in men or 3 in women. And in patients at high risk of bleeding, a closure of the left appendage can be performed with high rate of success at implant and low complication rate. These are the references. Thank you very much.